Hello friends, myself Dr. Ruchika Gar. Today I am going to tell you about Abruptio Placentae, which is a very important cause of antepartum hemorrhage. So Abruptio Placentae is the premature separation of a normally situated placenta from the uterine wall after the 20th week of gestation until the second stage of labor. So we know that there are two most important causes of antepartum hemorrhage. One is abruptio, second is placenta previa. So in placenta previa, the placenta is situated into the lower uterine segment, but in abruptio, the placenta is at normal location, but it is prematurely separated before the delivery, and it generally occurs after in the second trimester. It is the premature separation of a normally situated placenta from the uterine wall leading to vaginal bleeding. So it is also known as ablatio placentae. It is a significant cause of third trimester bleeding, and it is associated with significant maternal as well as fetal morbidity as well as mortality. So in the second half of pregnancy, we should always consider abruptio placentae in the differential diagnosis. So 1/3 of all antepartum hemorrhage is due to abruptio placentae, and it has an incidence ranging from 1 in 275 to 1 in 225 births, and women who had an abruptio in the previous pregnancies are at a greater risk. So as the risk of abruptio incidence increases, so what are the risk factors? Malnutrition, low socioeconomic status, multiparity, old maternal age. Now hypertension has a very significant association with abruptio placentae. So either pregnancy induced hypertension or chronic hypertension. Now other things is placental ischemia manifesting as IUGR, polyhydramnios, chorioamnionitis, vasculitis and other vascular disorders, abdominal trauma like fall or domestic violence or motor vehicle accidents are a significant cause of abruptio placentae. So lower seat belt should extend across the pelvis and not across the mid-abdomen where the fetus is located. Other causes are acquired maternal thrombotic disorders, tobacco use, smoking, premature rupture of membranes, cocaine use, fibroids or amniocentesis. So cigarette smoking increases a patient's overall risk of abruptio placentae. It affects the blood circulation to the placenta, which could theoretically lead to early separation of placenta. The most important predisposing factor is hypertension. So it has a very association ranging from 10 to 50%, because there is anoxic endothelial damage because of the high blood pressure leading to spasm of vessels in the uterine uteroplacental bed. So there is rupture of vessels leading to extravasation of blood leading to retroplacental hematoma. So basically hemorrhage occurs into the decidua basalis as the placenta separates from the uterus. Vaginal bleeding usually occurs, but it may be concealed behind the placenta. So what are the most important etiological factors? Maternal parity high, increased maternal age, low socioeconomic status, smoking, cocaine use, hypertension, premature rupture of membranes, hydramnios, amniocentesis, fibroids, accidental trauma, fall, domestic violence, and maternal thrombophilias, folic acid deficiency, sick placenta. These are the most important causes. So how does hypertension cause? There is spasm of the vessels leading to anoxic endothelial damage and leading to these vessels rupture, so leading to extravasation of blood. So these are prior abruptio. These are the risk factors of abruptio placentae. So how does it happen that the hematoma further separates the placenta from the uterine wall, causing compression and compromising the blood supply to the fetus? So I have told you there are two varieties Revealed, concealed or mixed type. In concealed, which is only 20%, the hemorrhage is confined within the uterine cavity. Detachment of placenta may be complete and complications are often severe. So, external visibly blood loss is not that much. In case of concealed variety, the hematoma is concealed between the uterus and the placenta. And revealed is 80%. The blood drains through the cervix. Placental detachment is more likely to be incomplete and the complications are less and less severe. In revealed variety, the blood may be fresh red in color, as well in concealed variety, the blood is dark, altered in color. So, concealed variety we can very easily differentiate it from the placenta previa by seeing the color of the blood in only. So, how can you differentiate placenta previa from abruptio placentae? One, from the history. In placenta previa, the bleeding is causeless, painless. But here some abdominal trauma or hypertension, it has a very strong association in cases of abruptio placentae. Then bleeding is always bright red in case of placenta previa. It may be dark altered, or because it may be mixed variety, or it may be fresh blood also. Fetal distress is not that common in placenta previa. In abruptio placentae, fetal distress is very common. Abdomen is tense, tender, rigid. Uterine tone is increased in case of placenta abruptio. Whereas in placenta previa, the uterus, the fetal heart rate is okay, and the placenta and the abdominal is not tense, tender, rigid. So that is characteristic of abruptio placentae. The uterine tone is increased. Uterine hypertonus is there. Abdomen is tense, tender and rigid, whereas it is normal in case of placenta previa. And from ultrasound we can diagnose. Ultrasound is a very sensitive for diagnosis of placenta previa, but here ultrasound has only 30% sensitivity for the diagnosis of abruptio. And management also differs. In placenta previa, many times we have to do cesarean section. In type 2 posterior placenta, type 3, type 4, whereas in abruptio placentae, vaginal delivery can be tried. DIC is a feature of abruptio placentae, and consumptive coagulopathy is common in abruptio placentae, whereas dilutional coagulopathy may occur in placenta previa because of over infusion of fluids. Consumptive coagulopathy generally does not occur. Renal failure, acute tubular necrosis, it may occur in cases of abruptio placentae but is not common in placenta previa. So now coming to the classification of abruptio placentae, class 0 is asymptomatic, class 1 is mild, moderate, severe. Now individual diagnosis of class 0 is made retrospectively after the delivery, when you see a blood clot or a depressed area on the delivered placenta. Behind the placenta we can see a blood clot, then we can make. Class 1, there is no to mild vaginal bleeding, slightly tender uterus, maternal BP, heart rate are okay because the patient is not hemodynamically unstable. There is no coagulopathy, no fetal distress. In class 2, moderate vaginal bleeding, moderate to severe uterine tenderness, and maternal tachycardia is there with orthostatic changes in BP and heart rate. Fetal distress is there and coagulopathy has started. So in class 2, fetal distress occurs and coagulopathy has started, whereas in class 3, heavy vaginal bleeding may be there, uterus is tense, tender, tetanic, and mother may go into shock. Mother is not hemodynamically stable, and coagulopathy, fetal death may occur, and hypofibrinogenemia may occur. So what are the symptoms and signs? Vaginal bleeding, uterine tenderness, backache, fetal distress, uterine hypertonus, IUD. So basically the collected blood, the decidual hematoma may be small and self-limited, and it's evident only after the expulsion of the placenta, retroplacental hematoma. So what are the complications? Fetal death, hypoxic brain injury, IUGR, neonatal anemia because of fetal hemorrhage also. So sinusoidal pattern may be seen in CTG in case of Abruptio placentae. Basically, there is fetal hypoxia leading to IUGR, growth retardation, and fetal death. So, what is covariary uterus? It is also known as uteroplacental apoplexy. Basically there is extravasation of blood into the uterus and beneath the uterine serosa. The blood insinuates into the uterine myometrium and into the serosa. The uterus is basically filled with, not the uterine cavity, the layers of uterus are filled with blood, and you can see this only at laparotomy. Per se, it's not an indication of caesarean section, but these myometrial hemorrhages, they will interfere with uterine contractions, and the myometrium in this area may become weaker and may lead to rupture of uterus as the uterine contractions increases, and it's a life-threatening obstetric emergency. Retroplacental blood may penetrate through the thickness of the uterine wall into the peritoneal cavity. That is, in cases of covariary uterus, we can find blood in the peritoneal cavity. Now, what are the other maternal complications apart from covariary uterus? Hemorrhagic shock, coagulopathy, blood gain access to the amniotic fluid through the ruptured membrane, and there is reduced metabolic exchange leading to fetal hypoxia. Tissue thromboplastin is released into the maternal circulation, uterine rupture, renal failure, and ischemic necrosis of distal organs like hepatic, adrenal, and pituitary. So, first of all, the patient may go into shock, and the shock may lead to renal failure and ultimately to acute tubular necrosis, and then to hepatic, adrenal, pituitary failure. Uterine rupture may occur, and DIC is very common because of the release of thromboplastin into the maternal circulation, and intrauterine fetal death and fetal hypoxia, fetal distress are very common. So, continuous fetal heart rate monitoring is very much required, and I have told you that sinusoidal pattern is specific for sawtooth like this is specific for Abruptio placentae, and other fetal distress features we will also get, late decelerations and all. So, thank you for your patient hearing. In the next presentation, I have discussed the management.